Really, it gives me immense pleasure to be with you for this Club Pulmonale meet. On behalf of Club Pulmonale, we are all very happy to welcome you all for this 084 meet. We have conducted so far 83 back-to-back monthly meetings. This is the 84th meeting. It is really a unique club which is disseminating knowledge across the southern part of this state. And we have got a wonderful doctors turnout for all the live meetings. During this pandemic and COVID times, we have been conducting this meet on this virtual platform all these 7 to 8 months. So all our meetings are very well patronized by the doctors. Today we have got a wonderful speaker, Dr. Bhagavaran. Hearty welcome to Dr. Bhagavaran. Welcome, sir.
Thank you, sir.
And friends, Merry Christmas and Happy New Year 2021. This 2020, we are going to finish it in a sad note, but we wish and hope and pray God should bless all of us, and 2021 should be prosperous for everybody, and we should be free of corona, everything. And friends, it is my pleasure to announce 7th annual conference of Club Pulmonale and our CME 085 on 24th January 2021, Sunday from morning 8:30 a.m. to 1:30 p.m. It is also going to be on the virtual platform. Chief guest for the conference, eminent speaker, renowned speaker, Dr. Sandeep Salvi, senior pulmonologist, chairman and director, Chest Research and Training Private Limited, Pune. And for guest of honor, another eminent speaker, renowned world popular speaker, Dr. Rajadhar, pulmonologist and sleep medicine specialist, director, Fortis Hospital, Anandapur, Kolkata. And for the conference, these are also session we are going to cover. Session 1 will be symposium on managing COVID in these populations, managing COVID in children, managing COVID in pregnant women, managing COVID in diabetes. And session 3 will be symposium on drug therapy forum, role of antivirals in managing COVID, when and how, role of fibrinolytics in post-COVID period. And the session 2 will be covered by Dr. Sandeep Salvi. It is a keynote address. The chief guest keynote address, the topic is changing paradigms in the pathophysiology and management of asthma in India. And the session 4 will be another keynote address by Dr. Rajadhar. Topic will be a comprehensive prescription for COPD. Session 5 will be a viewpoint on how COVID has changed my surgical practice. One of the eminent speakers will be going to give a presentation, and closing remarks by chief guest and the guest of honor. So friends, block the date. It will be a wonderful scientific feast, academic feast. We wish every one of you get connected and get benefited. Thank you. And today's our Club Pulmonale meet for 084. We have got a wonderful eminent speaker, Dr. V. Bhagavaran, MBBS, Dipandi, radio diagnosis. He is a vibrant, energetic practitioner and a wonderful speaker with all practical points. Current position, Managing Director, Interventional Radiology, Fitocare, Magnum Imaging and Diagnostics, Consultant Radiologist and Interventionalist, GVN Hospital and ABC Hospital, Trichy. And his academic qualifications, Dipandi Radio Diagnosis, Fellow of Royal College of Radiology, Fetal Therapy Training at St. John's Hospital, UK, Fellow of Cardiovascular Computer Tomography, And his publications, 8 publications, presentation more than 50, co-founder of Ramharan Singh in JNA, and he is authored chapters in the textbook of JNA, Atlas of Pituitary, Atlas of Pituitary Surgery, and areas of interest, fetal Dopplers, fetal interventions, and fetal therapy, and interventional radiology, and CT cardio angiographies, and oncoradiology. Okay, thank you, friends. I am also waiting for the beautiful academic presentation by Dr. Yes, Doctor. It is our happiness to hand over the session to you. Please.
Thank you for a wonderful introduction, sir. Hope I'm audible.
Yeah, very well audible.
So, is my arrow visible, sir, on the screen?
Yeah. 100%.
Thank you, sir. I thank Club Pulmonale for inviting me for this meet, and Dr.J.C.Sekar sir has been constantly asking me and updating me on all this. It's unfortunate that he couldn't attend it today.
Yeah.
Uh, So let's get into the topic today, and this is quite a long topic to be discussed. Though we have to revisit the X-rays, so that's more important. And we'll have a few basics on chest X-rays, and we'll get into cases. Now, with every case, we'll have the differential diagnosis, and we'll see how practically we can apply to it. I'm specifically skipping the cardiac vascular problems, cardiac valvular problems in this talk. We'll also have a few insights on the tubes, how to see the chest tubes and the venous lines, the PICC lines, how to actually see. Let's see that also in a few slides. So, yeah. So we all know, I need not tell all this because it's routinely obtained today. Even in the era of CT, still X-ray plays a very, very important role in a lot of uh, cases, as you all know. So in a normal chest X-ray, it's important to know what is normal. So we always see the lung in symmetry. We always see the clavicle in symmetry. We always see the trachea and the bifurcation here. So trachea is slightly towards right. It is because of the increased negative pressure more on the right side because of the straight vessels, straight bronchi. So there is a slight increased pressure on the right side. So the trachea is slightly deviated just off the midline to the right paratracheal region. So this is important. And always look at the symmetry and then the bones. So either you go from top to bottom, both sides, top to bottom or bottom to up, and from central to periphery. You won't miss any of the findings. It takes hardly a minute for us to see a chest X-ray, but chest X-ray is the most often misdiagnosed condition as CT has evolved more and more today. So we need to know whether it is a correctly exposed film or an underexposed film. So first of all, symmetry, as I told you, the clavicle should be medial and it should be equidistant from the midline. It is very important. And you always know the sex of the patient. Why sex of the patient is important? Sometimes the radiographer would not have asked the history. Sometimes you may see the breast on one side and no breast on the other side. You may pick up pulmonary metastasis. So in those cases, a CF breast which is operated and you could pick up a lesion which is there in the lung. So this is, as you know, so you could see here the two breast shadows, which is very well neatly outlined here. The scapula is very important. You should know which view are we dealing with, whether we are dealing with an AP or a PA. Now, in chest X-ray, it is the postero-anterior view, which is more preferred rather than the antero-posterior view. Right. Now, coming on to the path, as I told you, so this is the PHS radiograph, where you see the where you see the scapula out of the thoracic cage. It's very important. And this is the posterior part of the rib, and this is the anterior part of the rib. So the anterior part of the rib is always in an oblique angle in a PA view, whereas in a AP view, the scapula is more medial and it is towards it because the patient is not able to get up or a bedside X-ray has been taken. You could see the ECG leads here, and you could see the ribs are slightly parallel to each other. This is an overexposed film, but this is not. So you could see here there are multiple ribs you are able to see. There is one, this is two, three, four, five, six, seven, and eight anterior ribs are seen. So here there is a subtle flattening of the diaphragm, and you could. This is the over inflated emphysematous lung. So it is important. Sometimes you may need to take an expiration view, but it's always preferred to take an inspiration view in this X-rays. Now, when coming to a systematic approach, you know the lung fields. Will as we go into the cases, we'll see how to look at the lung fields on a chest X-ray. It is important to see the lung fields. It's important to see the trachea. Is it deviated? And is it the vascularity seen up to the end? And you could see the costophrenic angle. This is the cardiophrenic angle. This is the subdiaphragmatic space on the right side. This is the subdiaphragmatic space on the left side. Please note, this is the stomach bubble, or the gas shadow in the stomach bubble. It is very, very closely approximated to the diaphragm. You could see here, it's very, very closely approximated to the diaphragm. We'll see why it is important in the later slides. And here, this is the right dome of diaphragm, and you shouldn't see any free air here. So if that is there, then we should think of a case of a free air in the abdomen. It could be a perforative peritonitis. So these are the ribs, how it is seen. Sorry. So these are the ribs. That's how it is seen. This is the vertebra. This is the sternal position. This is the lateral X-ray where you see the lateral portion, and this is how the rib is. This is how the vertebra is represented. So this is where the posterior to anterior rib starts. So whichever the rib you see close to the vertebra is always the posterior part of that particular rib, which is important. So this is the rib. So from the posterior, this is the anterior. So posterior to anterior, this is what you see in a chest X-ray. So always these are some of the areas which is missed, which is the lower part of the neck or the supraclavicular region, and it's also the axilla. These are the hidden zones where you could find pathologies in most of the cases. Right. Again, I told you about the breast shadow in a female, which is very, very important. Sometimes you may not see a breast shadow on one side, so we need to pick it up. So in the systematic approach, we look at the pulmonary hilum. So the pulmonary hilum is a place where the vessels and the bronchi enter into the lungs. So here you could see here, you have the pulmonary arteries, you have the pulmonary veins. The bronchi is always smaller than the pulmonary vessels. So whenever you see the bronchi equal to or more than the diameter of the vessel, think of a bronchiectasis. So blood vessels can be seen. Predominantly 40% is obscured by other tissue. So you could see here, because of the ribs, because of the scapula, because of the soft tissue shadow, the breast, the heart, the sternum, these things actually cover few part of the lung fields. So again, coming on to, this is the diaphragm. Again, the pleural we have seen. I've told you about the stomach bubble, which is important. This is how a mediastinal representation goes into. So this is an image from the net, which is a copyright of the anatomy project which we did. So here you could see here, this is how the representation of the SVC comes, the representation of the LV, representation of the RV, the inferior vena cava, superior vena cava, the brachiocephalic vein, the aortic arch. From the lateral, that is the paratracheal stripe, to the distalmost curvature of the aorta. This distance is called the mediastinal width or the mediastinal diameter. So this cannot be more than 8 centimeters. So this is how this is represented. So this is the from the paratracheal stripe, you go into the maximum angle where it is measured this particular area, which gives the mediastinal width, which sometimes the mediastinal vascular pedicle may be widened in a few conditions, or mediastinal widening has to be reported only by this. But remember, all the X-rays has to be taken at a distance of 6 feet. This centimeter, whichever I'm going to tell you, the measurements which I'm going to tell you throughout this lecture, everything depends on the distance of the X-ray. If the X-ray is taken in the bedside with very close proximity of the X-ray beam to the patient, this diameters does not apply. This diameters, this measurements does not apply. This applies only to the cases where it is taken from a 6 feet distance. So that is the standard radiograph. Only in that actually you can measure the dimension with your regular scale. If an X-ray is given with your regular scale, you can measure these things. The next question is, how do I measure the cardiac diameter? The cardiac diameter is very simple. Draw a midline in the vertebra. Maximum diameter. Here the maximum diameter. Add both. This is the cardiac distance. Similarly, from the midline, the maximum dimension to the maximum dimension of the chest. This gives the transthoracic diameter. This gives the transcardiac diameter. So this cannot be more than 55%. So in adults, actually in older patients, you can give up to 60. Similarly, in case of AP radiograph, 60 to 65% is actually admissible. Right. These are the four important densities in a chest X-ray. You have the air, which is dark, which is completely dark because X-ray penetrates through it completely. Water is slightly whiter. Bone, which is completely white. Tissue is intermediate between all these things. Depends upon how much of vessels and how much of water content it has. Right. So the bone always has a high density here. You could see here, this is the air, which is actually black. And this is what blood, which is water. Tissue is intermediate. So these are the four densities that we'll have. With this only, we are saying, is it radio dense or a radio opaque one or a radio lucent abnormality? So these are the two words that we use. Radiolucency, radio opaque. You also have soft tissue densities. So these are the three descriptions that we use in a chest X-ray. Right. This is how a lung is represented on a chest X-ray. It's not a CT. In CT, you can take multiple sections, you can reconstruct. Whereas in a chest X-ray, this is what is represented. So you could see here on the right side, of the patient, you could see here the three divisions, the upper lobe, the middle lobe, and the lower lobe representation. This is how in a PA radiograph it is. So the lower lobe actually is separately seen only in this part, whereas it overlaps the middle lobe and the upper lobe. In the left, you could see here, this is the upper lobe, which is actually showing the predominant involvement or predominant representation. And the lower lobe is here. This is the fissure, the oblique fissure, and this is the transverse fissure. So this is how the representation is in the chest radiograph. In the lateral radiograph, on the right side, you could see here, when you draw a line and you cut it at the midline at the level of fourth rib or the fourth dorsal vertebra, you get the upper lobe, you get the middle lobe, and you get the lower lobe. So here you could see this is the sternum. So from the sternum, you have the retrosternal space. So this is the sternum, retrosternal space, the upper lobe, middle, and the lower lobe. This is how the representation on a lateral radiograph is. Sometimes we tend to get a lot of confusion, which lobe, where it is. So this is how this is a diagrammatic representation of how the lobes are represented. Similarly, a right lower lobe is represented very high. So there is always a fusion. There is a mixing of lobes in the mid segment. Here you could see here again. So this is the right upper lobe, which is represented. So this is how it is in the lateral radiograph. This is the right middle lobe, which you could see here, the middle lobe has more representation in a PA radiograph rather than the lower lobe. Again, in the lateral, you see the wedge. So from D4 or D5 level, when you draw a line and cut it and make it a wedge, this is what the right middle lobe is. Similarly, right lower lobe, this is how it is represented. In lateral radiograph, this is represented. So whenever you see a line or whenever you see a shadow which is almost close to the vertebra, this is always in the lower lobe. So this is how, I need not explain this. This is how a minor fissure and a major fissure is represented. So in the major fissure, D4, D5 level, draw a straight line to the cardiophrenic angle. From here in the D5 level, just take a straight line. So this is the middle lobe, the upper lobe, and the lower lobe. Similarly, on the left side, you have the left upper lobe, which is predominantly represented. So when you see a large shadow here, predominantly committed as left upper lobe, this is how it is represented in the left lateral view. This is how the left lower lobe is represented. Look at, so here you could see here, left upper lobe which is represented, left lower lobe which is represented almost fusing with the upper lobes. And this is how a major fissure line is drawn. Right. What is sellout sign? There's a common word that we use. So in an if there is an intrathoracic radiopacity, that's important. If there is an extrathoracic radiopacity, the sellout always happens with the bone, not with the intrathoracic structures. When you have an intrathoracic radiopacity, if it is in the anatomic contact with the border of the heart or the aorta, that will obscure that particular border. So it means it is anatomically contiguous with that border. For example, now this there is a straightening here and there is a retrocardiac shadow. So this retrocardiac shadow predominantly represents the left lingular segment. So these are the important points that we need to know when we look into the chest X-ray. So first of all, the symmetry, whether it is taken right, and look at the male or a female. See for symmetry, as we told you, equidistant. Is it not rotated film? Is there any other abnormal shadows? Start from upper to down, which is easier. Similarly, upper to down on the left, and always go from the midline to the lateral, from midline to the lateral. Look at the bones, come back to the heart, look into the scapular or the extrathoracic shadows, come down, see the stomach, and also see the subdiaphragmatic region. And you see if the costophrenic angle and the and the cardiophrenic angles are sharp. So that is important. They should be absolutely sharp. So these are the common things that we need to look into. Right. So this is how it is. I told you how to measure the heart, how to measure the mediastinum, all these things, it is there. So let's get into a few cases here. So once we get into the cases, we may able to understand a lot of things actually. So you could see here, sometimes you see a complete collapse of the lung. So that's why I said this is the endotracheal tube which has gone straight into the right main bronchus. So that is causing obstruction to the left main bronchus and lead to a complete collapse on the left side. So this is important. When you see a shadow, so this is called a complete radiopacity of the left lung. So understanding the pathological process is again very, very important. Sometimes X-ray will not give you 100% detail of a lot of things. Similarly, the question comes when somebody sees a chest X-ray, when do I order a HRCT chest? So what is HRCT? What is a CT chest? What is a CECT chest? Now HRCT is nothing but a high resolution computed tomograph, where you actually take a less than a millimeter cuts, like 0.6 millimeter cuts. Now we do. Initially, HRCT was described as 1 millimeter cuts with 10 millimeter interval. Yes, still we do that. It's a good inspiratory film. The patient has to keep completely inspired during the study. So now we can do even much lesser. We can do a 0.6 millimeter sections, and we can give a gap of 5 millimeter HRCT. So you can even reconstruct with that, and actually you can get a lot of good details with that. The problem with HRCT is if you want a tracheal reconstruction, if you want a bony reconstructions, it cannot be done properly, number one. Whereas in a helical CT, where it is a complete CT of the entire CT chest without leaving any area, that you can give a good reconstruction and you can get a good tracheal view, tree view, everything, whatever you want. If there is a tracheal stricture or a tracheal narrowing, stenosis, everything can be beautifully picked up. If you want to do a virtual bronchoscopy with a CT chest, you can do with that. Whereas with HRCT, you cannot get a good reconstruction. In HRCT, you cannot use a contrast. You have to use a helical CT for a contrast chest X-ray. You cannot use a HRCT for that. When you have a problem, again, go back to CT chest. Now there are going to be few cases. You can see the cases for every case. Probably I'll give you for 10 seconds probably where you can look into and just try to get the diagnosis by yourself. Now this is first case. Okay. Now you have a thick-walled rounded cavity here. So it's a thick-walled, very rounded cavity. In India, when you see this kind of a lesion, the first diagnosis would be a cavitating tuberculosis. When you see a cavity, it is important to see, is there any fluid levels? If there are fluid levels, then probably you're dealing with an abscess. If there is a crescent sign, it means that there is a shadow here, which can cause a crescent of air above, then probably you're dealing with the intracavitary aspergillosis. These are the things that you need to look. Whenever you have these things, always look at the other areas, look at the costophrenic angles, look for mediastinal widening, and is there anything else? This case is a thin walled cavity. You could see here. This we did a biopsy, and unfortunately, this turned out to be a squamous cell carcinoma. Now, in India, though we have uh, diagnosis of tuberculosis, which is quite common, still cancer also has a higher commonality today. So here is parahilar, more central. So this is a squamous cell carcinoma, and turned out to be a squamous cell carcinoma here. So the important diagnosis here was a TB. But when we did a CT, we found it was irregular, and all the other no sputum production, nothing. This was taken for a health checkup view. So we had to go and do a biopsy, right? Now, this is what I was telling about. When you have a cavity, next case, this is a cavity where you have the fluid level. So this is a lung abscess. So when do you call a wall thick and a wall thin? So keep the wall thickness at 3 millimeters. How do I measure it? In a regular chest X-ray, you can take a scale and you can measure it. When this is obviously thick, more than 3 millimeter, it will be seen. When it's a pencil line, it is a thin walled appearance. This is the another case here. Old person. So here you could see here, there is a, looks like an hyperinflated lung. Here you could see a lot of ground glassing and sort of opacities here. Similarly here, you could see here, these things. So, but what do we see here? Is this pathological or this pathological, right? Now, when you say this is pathological, now these are the confusing cases. When you say this is pathological, it means you're saying that this is a emphysematous lung, but this is not an emphysematous lung because see 1, 2, 3, 4, 5, and 6. So only 6 ribs are seen, and the diaphragm is still a dome-shaped, nice diaphragm. It is not flattened out. So this is not an emphysema, and you could see the vascular markings which is seen up to the outer third. So it means that this is not a hyperinflated lung. Whereas here, you could see that there is a shadow and we are not able to see the cardiac shadow better. This is what we call it as silhouetting, where the left lower lobe is completely atelectatic, and that is causing the left heart border to silhouette. So this is just an overinflation and not a hyperinflation, because this is a compensatory mechanism which is being taken up by the other lung. Now, there's another case here. So this is a female. Obviously, the breasts are seen, and you could see here multiple patchy, irregular opacities. Now, the question is, when you have a opacity, how do I call it airspace? How do I call it vascular or a septic emboli? How do I call it could be a hematogenous metastasis? Now, if you imagine the structure of an alveoli, the alveoli is always irregular. Alveoli is irregular because the sac is irregular. So when a fluid or tumor cells, or it could be debris or an infection which happens in the alveolar sacs, it is always an irregular opacity. The hematogenous metastasis generally go and sit, if you know the structure of the alveolar sac, the central has the respiratory bronchiole. It is accompanied by the artery, that is the division of the pulmonary artery, and the pulmonary veins are in the walls of the alveolar sac. Now, hematogenous mets, when it goes and actually spreads there through the pulmonary artery, it is suspended by the surrounding alveoli. It is suspended by the surrounding alveoli. That is why the metastasis in 90% of the cases are appearing cannonball, that is perfect round. The perfect rounded hematogenous metastasis is because of the pulmonary arteriole spreading the metastasis hematogeneously, whereby the air in the alveolar sacs create a negative pressure that suspend it like a ball in the center of the airspace. That is why it is actually a very clear rounded cannonball appearance. Whereas alveolar opacities are always irregular, fluffy, or you can call it irregular or a ill-defined or a fluffy opacities. The other structure in the lung is an interstitium. So interstitium forms the framework. When there is an interstitial pathology, it causes a interstitial fibrosis. It can cause ground glass opacities like what you see in COVID. And you can see the interstitial pulmonary fibrosis, or you can see the pulmonary edema, which can cause thickening of the septa. Now, this septal thickening are lines, or it can be lines with small nodularity. When it's lines, it is called as reticular. When it has lines and small studded areas, so that's called a reticulonodular opacities. Right. Here you could see here multiple patchy opacities. These turned out the patient had a very high grade fever. The counts were almost 26 to 28,000. So this was a pneumonic patches, multiple pneumonic patches. In case of septic emboli, if the patient is septic and patient is having a very high fever and non-relenting cough, there can be a septic emboli. Now, septic emboli usually is in different stages. It can be nodule, it can be cavitating, it can be having fluid levels, it can be anything. It can be even present as a wedge-shaped distal lung collapse. So all these things can happen with a septic emboli. So this is how the consolidation occurs, the nodule. So when do you call an opacity nodule? When do you call it as a mass? Similarly, the size given criteria is 3 centimeters. So any nodule, any opacity which is less than 3 centimeter, you call it nodule. Anything more than 3 centimeter, you call it a mass. Right. So this is what we saw. See, this is the lobar consolidation. It's a diffuse consolidation here. It's an ICU patient going in for an ARDS. This is multifocal. Again, a case of atelectatics areas. You could see this is the golden S sign we call this because of the upper lobe bronchial mass, which is obstructing, that causing the upper lobe collapse. When you have an interstitial pattern, always ask for a CT. Sometimes this may be misleading. In old ages, it can be normal, it can be emphysematous, or it can be a chronic interstitial lung disease. So in all these cases, HRCT is a must. So as I told you, this is a solitary pulmonary nodule, but here you could see multiple nodules. As I told you, the common metastasis, when it is hematogenous metastasis, it is always a rounded cannonball because it is suspended due to the airfill column. Another case here, you could see the bronchial obstruction, thereby causing complete collapse of the right upper lobe. So this is again a golden S sign, turned out to be a central type of bronchogenic carcinoma. So in cases of consolidation, you see the air bronchogram. So whenever you have an obstruction, you don't see the bronchus filled with air. So this is called air bronchogram, which indicates the bronchus is still open, that there is nothing obstructing the bronchus. It is the peribronchial inflammation that is causing to consolidate. That's what it means. The air bronchogram means that the peribronchial region getting to consolidate and getting infected. Whereas when air bronchogram is not seen, probably you're dealing with a central obstruction. Now, another case, upper lobe collapse consolidation here. It's a baby here where you could see a complete collapse consolidation. Another case of middle lobe consolidation. Now, when we actually put a line and when we imagine what I showed you in the X-ray, how it gets represented, this particular area, this is how the middle lobe is represented, which surrounds the right heart border. So that's the middle lobe. Again, do I have to say middle lobe? Yes, you can say in this case, it is definitely middle lobe, or else you can say it is in the mid and lower zone of the lung if you are not sure about which lobe of lung this is involving. How do I classify the upper two? Any lung structures from the anterior margins of the second vertebra and above, second rib and above, this is the upper zone. Between 2 and 4 is a mid zone. Anything lower than that is the lower zone. This is again a left upper lobe consolidation in a young individual, a complete consolidation who was an alcoholic, who actually aspirated completely on the left lateral position, and it's a huge consolidation which took a long time to resolve. Right. So as I told you, it's important to differentiate whether it is a soft tissue, there is a consolidation, peribronchial consolidation, how is the bronchus? Any other opacity, is it alveolar or it interstitial? So that is what we were saying. Is it alveolar or is it interstitial? When alveoli is filled with fluid, mucus, tumor, cells, or edema, whatever it is it does not give a air exchange. See, in COVID also, what happens? There is a reactionary edema there that's actually sitting, falling in the inflammation. The interstitium is getting inflamed. So the air is not actually whatever the amount of oxygen that you're going to give. When you're going to give, it's not going to penetrate through the abnormal. That's why you're giving a high flow oxygen. The high flow oxygen tends to go replace the fluid from the alveolar sacs, thereby aiding the lung to actually get more amount of air so that the oxygenated blood gets more oxygen. So in interstitial, it is important to know the vessels. Is it radiodense or what? So whenever you have an interstitial pattern, it's always important to know the pathology. We have to go in for a HRCT. Right. So this is the pattern which we were talking about. This is a reticular pattern. So slightly older X-rays. So it's a complete reticular pattern. You see multiple interlaced lines. You're not very sure what it is. Sometimes cystic areas can be seen. So predominantly, this is a chronic ILD. So this is what we were saying, a chronic interstitial lung disease. Here you could see there is multiple nodular pattern. Now this nodular pattern may be of miliary tuberculosis if it's only nodular in India, or it can be miliary metastasis from the thyroid or from the renal uh, cell carcinomas, number 2. But have a close look to see if there is any line pattern. In miliary tuberculosis, from the top to bottom, the entire lung is studded with miliary nodules between 2 to 3 millimeters. So what is miliary nodules? Miliary nodules are nodule which is between 2 to 3 millimeter. Anything more than 3 millimeter, you don't call it miliary nodules. So this is how it is. You could see, you don't see lines in miliary nodules. So when you see lines, this could be a reticulonodular pattern. You always go in for a this thing. As I told you, this is how the classification goes. Miliary nodules less than 2, micronodule 2 to 7, pulmonary nodule up to 3 centimeter, mass which is more than 3 centimeters. Right. Let's go into the other case. Now we have seen the cavities, how it looks like, the lung abscess which we have seen. We have also seen the interstitial pattern. To differentiate it from alveolar pattern, we have seen the metastasis which is actually there. Now this is another case. Take a closer look at this case. Don't worry about the lateral. In AP itself, it's very, very nicely seen. Only in lateral, you need to know which lobe to be involved. So this is the upper lobe involvement. You see a thick walled cavity here. I'm sure you all agree to it. When you see a wall of the cavity visible and very thick, not a pencil line, it's like drawing in a marker sketch. This is thick walled. Again, you could see here, there is a cavitation. Yes, there is a cavitation here. You could see here that the fluid levels is there. So this is the lung cavity, which is going in for a abscess formation. These kind of cystic cavities is also possible today in COVID. We have seen a lot of cases in a recovery phase going in for necrosis and having a jelly-like fluid. We have aspirated close to 8 cases thinking this could be an abscess because the patient was not settling down. Fevers were spiking even after the 4th week of fever. The patient has recovered from all the other parameters. We've tried to aspirate almost 8 cases. All these 8 cases turned to be jelly-like fluid in a COVID lung. So, but I don't know for what reason, when we took that fluid out, the patient had a good relief of few symptoms. And the patient, two to three patients, actually, 3 patients, old age patients, became better after aspiration. So this is how the cavitation was good. Again, this is another case. Take a closer look at the case here. Could see here, patchy opacities. These are patchy opacities, irregular from the hilum to the periphery. The rest of the lung fields are relatively clear. So this turned out to be a tuberculosis in India. So in India, why I have put a cavity for a SCC, because when you have a cavity, when you have a pattern which is not fitting into anything in India, this could be tuberculosis, as we all know, where biopsy is mandatory. But there are a few cases where tuberculosis can have varied presentation. So the miliary tuberculosis, as I told you, it's only 1 to 3 millimeter. Anything more than 3 millimeter with the line anywhere you see a line or a reticular shadow, that is not miliary tuberculosis. So this is a miliary tuberculosis which can happen from superior to inferior. Extensively it can be done. Nodules are seen here, completely studded with nodules, not sparing any particular lobe. Again, take a closer look at this cavity. This cavity has a small rim of crescent sign. This is what we call it as the intracavitary aspergilloma. It's a fungal ball within the cavity. So the manifestations of tuberculosis can be from consolidation to cavitation to granuloma, miliary tuberculosis, etc. In later stages, what we see is fibrosis and calcifications. Let's take a look at the other case now. This is the other case now. We have seen now tuberculosis, the cavity, including tuberculosis, SCC. We have seen consolidation pattern also in tuberculosis now. So this is a case. Let's see the finding here. This is a case of COPD. You could see here large area where there is. Yeah. Okay. So this is the area where you could see a large thin-walled air-filled cavity here. The diaphragm is pushed down, hyperlucent. So this is a case of a COPD. So now this is important. Now hyperlucent lung, and you can see the thin-walled bullae, which is a large bullae sitting in the right upper lobe. Why it is right upper lobe and not right middle lobe? Because this is not saluting the right heart border or close to the right heart border. This is very much peripheral. So most commonly this should be in the right upper lobe, which is actually represented here also. This could be hyperinflated lung. So when you have an hyperinflated lung, now the lung is predominantly black and it's hyperinflated. So the most important diagnosis in your mind should be a pulmonary emphysema. So what are the signs of hyperinflation? The flattened diaphragm, increased radiolucency, the anteroposterior diameter is increased when you take a lateral X-ray, cosophrenic angle is obtuse, ribs are widely spaced. When ribs are closely spaced, you think of fibrothorax or loss of lung volume. Again, this is what I initially told you, the increased retrosternal air space. Now, there should not be enough, there should be only a small space where you can draw with a marker. That's what the space between the retrosternum and the cardiac shadow should be, or a sternum from the cardiac should be. When it is more than that, it means that the retrosternal air space is widened. So that is very important. In pulmonary emphysema, there can be right ventricular enlargement, as you all know, because of pulmonary hypertension. And there can be peripheral pruning of blood vessels because of pulmonary hypertension. So this is what we were saying. So this diaphragm, when you draw a line from the cosophrenic angle to the cardiophrenic angle, when you take this maximum measurement, this should not be more than 15 millimeter. This cannot be more than, whether it is AP or a lateral, this from the cosophrenic to the cardiophrenic in lateral, or in the PA, you say from the cardiophrenic to the cosophrenic, this cannot be more than 15 millimeter. Now, again, I'm emphasizing the point, this is applicable only to X-rays which are taken at a standard 6 feet distance. That's important. Now, when this 1.5 centimeter is actually obliterated, it means it is a hyperinflated lung. Simple. This is another case. This is the shadow here, which has been marked. Yes, this is seen here. Yes. So look at this shadow. Look at this shadow. This is actually which is where in the minor fissure. So this is actually in the minor fissure. Why? Because again, you could see the margin, which is towards the pleura. You could see here, the curvature is towards the pleura. That's why this is in the minor fissure. It's a pleural based opacity. So this is a pseudotumor where minor fissure is creating as evidence. So sometimes you have a doubt in this case, what am I dealing with? The answer will be through a HRCT. But in this case, you could see the cosophrenic angle is blunted. It's completely blunted here. And you could see this opacity is obscuring the pleural margin. It's actually pleural continuing. So that's how it is, the large area of attachment towards the pleura. So this should be a pleural opacity. This is another case. I could see here, large opacity. Yes, it's here. This is the opacity here, which is going up to here. So it's a posterior, up to the posterior. So from here, it goes up to this lung. So this is where it is. So it is in the right middle as well as in the right lower lobe. So here you could see here. That's the right lower. So this is a large pneumonic consolidation. So In this case, sometimes a lobar segmental anatomy trying to get inner chest X-ray will be useful. In a Klebsiella, it's usually a bulging fissure sign. You could see the concavity is towards the inferior aspect. The concavity is towards the inferior aspect. So this is the bulging fissure sign in a case of Klebsiella pneumonia or a Friedlander's pneumonia. Sometimes Klebsiella pneumonia, you can see this particular bulging fissure sign of minor fissure if it is involving the upper lobe and there is a fissural bulge. So in this case, Klebsiella pneumonic diagnosis can be made much earlier. So this is another case. I hope everybody understands that this is an obvious cardiomegaly. Obvious cardiomegaly is there. So you draw a line in the midline, maximum dimension here, from the midline, the maximum dimension here. So you measure the cardiac diameter. So from here to here, you measure the thoracic diameter. So it cannot be more than 60 in whatever case it is. Obviously, it is dilated. So there is a cardiac dilatation, and you could see there is a accentuated interstitial markings here, curly lines. There are multiple wavy lines are there, and you could see the curly lines. This is the curly is because of vessels which we are using. Curly B is here. That is K, which is here. This is after 24 hours of diuretic therapy. The patient came with severe congestive cardiac failure. After diuretic therapy, you could see the lung is clear. So in the stages of congestive heart failure, suppose you see abnormality, there are 3 stages, stage 1, 2, and 3, where you see in 1, you see the redistribution. In stage 2, you see the curly lines, which is peribronchial cuffing, because the pressure is increasing. The pressure is increasing because of the left ventricular failure. The left ventricle and left atrium is overloaded. So the pulmonary vein pressure is high. From the pulmonary artery, blood is trying to come in. Whereas since the pulmonary vein pressure is high, it is not able to cross the alveolar sac or the oxygenating vent, and it has to come into the pulmonary vein. So this is not happening. So what happens? The alveoli get edema. So that's why ground glass opacity occurs. Once the pressure goes on building, then what happens? There is a redistribution. The body tries to redistribute the blood to the upper lobes of the lung. It is not happening. So there is alveolar edema here. When there is an alveolar edema, still the fluid starts to accumulate. Alveoli is not able to accommodate, so it goes into the interstitium. So that goes to interstitial thickening. Since the fluid is very high, the pleura is actually reacting, and there will be excess of fluid is actually pushed into the pleura, and the production of fluid is more than compared to the absorption capacity of the pleura. So you get a pleural effusion. On a slow progression or accumulation of this particular condition, you get consolidation, air bronchogram, and all those stuffs. So this is how the vascular pedicle, I told you. So this is the right paracardiac stripe, which is here. This is the maximum curvature of the aorta. This is the vascular pedicle or the mediastinal dimension. So this is how the mediastinal dimension is measured. So this is curly A lines. It is from the hilum to the upper lobe. So curly A lines are from hilum to the upper lobe. They contain the interlobular septa and the lymphatic connections. Curly B lines is here. You take a closer look. It is close to the subpleural region because the edema in the interlobular septa. So what are the important points that we need to look into when you see a pulmonary edema? You have the cephalization of pulmonary vasculature, where there is a redistribution of blood flow to the upper lobes. There can be peribronchial cuffing. Curly A lines is always central. Remember, curly A is always central. B is peripheral, and you can see the pleural effusion. Curly A is oblique. Curly B is or horizontal lines. So this is the fluid in the minor fissure. Again, this is what we saw earlier as a bulging fissure. Sometimes it can be a fissure which goes towards the pleura. In those cases, you can see it could be a pseudotumor. So this is a case of alveolar edema where it can go for. Now, what happens when fluid goes on into the airspace over a period of time? The fluid does not get exchanged, so it stays there. So it slowly gets consolidated. So there is a consolidation phase. As it gets consolidated more and more, the patient is becoming more going to a respiratory failure. That leads to adult respiratory distress syndromes, where there's a diffuse bilateral patchy infiltrates, homogeneously distributed cases. This is a case of bronchopneumonia. There are multiple small nodular and reticulonodular opacities predominantly distributed in the basal segments in children. Now let's say this is another case. Now locating the opacity is very important. So here is the opacity. As I told you, the opacity is peripheral and the concavity is towards the pleura. So this is not a intrapulmonary nodule. So this is from the chest wall and not from the lung. Another case where you could see the pleural effusion here. So the pleural effusion evaluation sometimes may be very difficult, and in all cases we cannot be sure of exactly how many ml. I've seen so many consultants asking me, sir, how much of ml will be there, kindly gauge. So it's only the approximation that we can give, because even when you do an ultrasound or when you do a CT, it's very difficult to evaluate the exact amount of volume. Plus or minus 100 is an acceptable range. So these are the examples. So you could see here the blunting of costophrenic angle here. The blunting of cardiophrenic angle happen here. Obviously, you see the cardiomegaly. So this is the pleural effusion. And there can be a concave meniscus. Always there is a concave meniscus here. So the diaphragm, now the pleural fluid always silhouettes the diaphragm. So there is a silhouette sign with the diaphragm. So in massive pleural effusion, the lung can be completely white out. So when do you call a pleural effusion massive? That's a common question. When do you call it as mild? When you call it as moderate? When you call it as mild? Now, in which X-rays does it apply? When you take an X-ray in a standard 6 feet view, when you take an X-ray in a standing position of the patient, then if it actually crosses the anterior border of the second rib, this is a massive pleural effusion. Anterior border of the fourth rib, it goes up here, moderate. Anything less than the fifth rib, it is always called as a mild pleural effusion. When it's actually shifting the mediastinum, it is always gross. That's all. So that's how we call it. So second, 4, below 4. You can easily remember. So similarly, above second rib, you call it as upper zone. 2 to 4, you call mid zone. Below 4, you call lower zone. So when only lower zone, mild. Up to the mid zone, moderate. More than the mid zone, it is a massive pleural effusion. So this is called the lamellar effusion. Sometimes, the collection is between the lung surface and the visceral pleural surface. So it's not within the pleura. Sometimes there can be a lamellar effusions in kids. This is what I was telling. See, the stomach bubble should always be in close proximity to the diaphragm. When the distance is increased, always think of a subpulmonic effusion. Here you could see here, the right costophrenic angle is obliterated. So this is a pleural effusion. That is cardiomegaly. Sternotomy wires are seen. There are multiple, you could see here, there are curly A lines going in. So early congestive cardiac failure is what we are dealing with. Sometimes you see a encysted or a loculated pleural effusion, which we have seen already, which is the best method to aspirate it. You can do it by CT or you can do it by X-ray, ultrasounds. This is what we have already seen. This is from the net, and you could see here, this is the middle lobe encysted or an encapsulated effusion, which is also called as phantom tumor. Okay. Sometimes you get a complete collapse of the lung with the trachea being pulled to that side. So this is a collapse, whereas push to the opposite side, which is always a massive effusion. Sometimes minimal effusion, put it in the ipsilateral position. When you want pneumothorax, put it in the opposite side lateral position, right? So here you could see a well-defined parahilar nodule. So this is obviously more than 3 centimeters. So we call it mass. So CT done, and this was a biopsy to have a malignancy. No other lesion was there. So this patient went in for a pneumonectomy, and this is how the mass looked like. Now, where is the lesion? Looks like a normal chest X-ray. Looks like an absolute normal chest X-ray, but there is an abnormality here. When you take a closer look at this case, look at here. You see the line. Yes. So that is a very small pneumothorax, which you see in the upper lobe. So here you could see here, the vessels are going up to the periphery, whereas here you don't see the vessel in the periphery. Right. Another case where you see a thin-walled bullae here, which is in the right upper lobe again. Why upper lobe? Because this is not surrounding the right cardiac border. So this is in the right upper lobe. So that's what it means. Sometimes, pneumothorax can be confused with the skin fold. So it's always important to see this is a pneumothorax, but this is a skin fold where you see the vascularity going beyond this fold. So this is an obvious skin fold. This is the most common confusion. In a lying position, when the patient is lying predominant amount of the time in an ICU, where you taken a bedside X-ray AP view, where you see a deep sulcus sign, where pneumothorax goes very deep in the cosophrenic space. There is obvious hydropneumothorax. When there is a cut, obvious fluid level, air fluid level, you call it a hydropneumothorax. When the pleural thickening is irregular, again, how do you say this is pleural thickening? It's not in the lung. There is an irregularity. The cosophrenic angle is obliterated, base towards the pleura. It is irregular. So this is a pleural thickening. Right. Again, another case, a hyperinflated lung. But you could see here, this is a complete collapse of the right lower lobe where there is a right pneumothorax. It's a complete lobar collapse. This was the chest tube was inserted in this patient and there was a re-expansion. Again, multiple cannonball appearance. It's a nodule, metastatic lung cancers. A single nodule here, which is in the right upper zone. Yes, so this is the right upper lobe pulmonary nodule. You could see here, there's a patchy, irregular, confounded opacities here. You could see here some cavitating lesion. The pleura, apical pleura is thick and it is there. So this is a case of tuberculosis. Now in India, all the other cases is tuberculosis. Again, another case where there could be a Hodgkin's disease. This is a case of, sorry, yeah. So these are few cases of sarcoidosis where you could see the 1, 2, 3 garland sign, where you call it as, where you see the paratracheal node here and bilateral hilar prominence, which can go in for a severe fibrosis as you go in and in. This is another case, a child where you could see here. So that is the mediastinal widening. A post-traumatic case in a child where there was a aortic dissection in this case. So it is important to know whether there is a widening of the mediastinum or not. That's why this case was put. So again, this is a case where you see the sternotomy wires. There is a gross cardiomegaly here. So there is a gross cardiomegaly. The upper lobe vessels are seen, and you can know which is the left atrium, the right atrium. So you could see here the SVC, IVC entering here, and the right atrium is bulged out, and there is actually a pericardial calcification here. If you take a very close look, the mitral valve which is actually replaced in this case, and there is a huge cardiomegaly. So all these informations actually we can get it by means of chest X-ray itself. I'm not going into the congenital cardiac abnormalities here. I'm just getting into a few other cases. So here, another case, congenital cardiac abnormalities have not added. So what is obvious in this case? The trachea is slightly towards right. Compared to the left, compared to the right, the left is actually hyperinflated. The volume is high. So what do you think in this case? Whenever you have a child with one side hyperinflation of the lung, always think of a foreign body. So this is a case where the child has actually swallowed a groundnut and this was the lesion. Another case, hyperinflated lung, another foreign body. You could see here another case where there is a foreign body here. Another case of foreign body in the left main bronchus, which was a nail in this case. So it is important to know where actually the foreign body has impacted, whether it is in the esophagus or in the trachea. Many times there is a confusion. Here you could see it's a typical esophageal location, which is below the cricopharynx, which is actually a end-on view, whereas this is the end-phase view. Whereas in the mid-esophagus, this is how it looks, whereas this is opposite what is there in the trachea. Right. So these are a few of the cases where there was mediastinum. You could see a surgical emphysema, and you could see the air silhouetting the paratracheal stripe. So this is a case of mediastinal emphysema. This is another case of pneumomediastinum, where you could see a spinnaker sail sign appearance. There's an angle of the angle wing sign, angel wing sign. So this is the spinnaker sail sign, which has both pneumothorax as well as pneumomediastinum in this case. This another case of pneumomediastinum. As I told you, in the bedside X-rays, in the pneumothorax, you see a deep sulcus where the costophrenic angle goes deeper, whereas in pneumomediastinum, the cardiophrenic angle goes deeper. So this is called the Neclario V sign, right? Now let us check a few of the devices. With this, we come to a conclusion. Now it is important to know which tube, where it is being inserted. So if you want, you can take this as a screenshot. This is a complete check devices from the NHS. You can know where it is. Endotracheal tube, it should be 3 to 4 centimeter above the carina. Tracheostomy tube, tip lies 1.5 to 2/3 from the stoma and the carina. Where the CVP should be placed, how is the dialysis catheter placed, all this has been given. So that is important. So here you could see obviously the Riles tube which is put has turnover and come to the mouth. Again, you could see here, this is the central venous line which is coming, whereas the nasogastric tube which is put goes into the main bronchus and has come into the right side bronchus. It is actually an intrabronchial location of the nasogastric tube. All this can be easily answered. Now here again, you could see that's the endotracheal tube which has gone into the esophagus. You could see the distended of stomach and has straightly gone into the esophagus, and the baby is still suffering from respiratory distress, and this turned out to be, so it was removed and repositioned. Sometimes it may be difficult for them also. So this is how the anatomy in chest X-ray looks like. So the right brachiocephalic vein comes here, the superior vena cava, left brachiocephalic, the left IJV, the left subclavian. So this is how the SVC enters in the right heart. This is how the bronchus is there. That's why I told you in the paratracheal stripe, always look for a shadow from where you should calculate the mediastinal widening. This is the obvious catheter which is in the SVC. You could see the catheter is gone into the SVC. Now, many cases today are the chemo has been administered using a chemo port. Now, where is the chemo port is the most common question. Is it rightly positioned? So again, you could see this is the tube here, which is gone. And there's so many confusing tubes here. So there is a large shadow here sitting in the right paratracheal stripe. This kind of a large shadow was not there before the tube insertion. So this turned out to be, this tube was inserted and there was a puncture in the aorta and the branches of arteries, and there was a large hematoma here. So the tip was withdrawn and it was put on the opposite side and it resolved on its own. So this is another case where the endotracheal, where the central line is actually going towards the left side, which is not the usual position. If there is an SVC, it has to come straight down here, whereas here it is going into the aorta. So what are the type of cardiac devices? Again, see, there can be this is a 2-lead actually dual chamber pacemaker, and there can be a single chamber pacemaker. This is how the normal position looks like. Same dual chamber pacemaker, one chamber is fine, the other chamber trace it, it has come into the liver. So it has come into the liver. So this is not the normal position of the chest. This is the single lead pacemaker where actually it has not gone into the RV or RA. It is only still in the SV. So this is called as a Twiddler syndrome. So still the wire is there. The wire cannot be seen in the level, just at the level of the right main bronchus. It has to go still lower to enter into the RA, where it has to go and stimulate this sinoatrial node. This is a case of umbilical venous catheter, which is taken a curve and has gone up. So this is the umbilical venous catheter. So sometimes the patient may have the umbilical venous catheter also. So this is another case. Sorry, yeah. So large air under the diaphragm. So sometimes the abdominal conditions can be picked up. So this is the perforative peritonitis. And this is a case where there are multiple fluid levels. A large distended single bubble of the stomach in a child with vomiting on a chest X-ray. So this is a hypertrophic pyloric stenosis which was diagnosed with a barium meal. So you can also pick up sometimes the patient may present with the chest pain. When an X-ray is taken, you might find a new air under the diaphragm, and also you can find a lot of air fluid levels, and vomiting may be the cause. So that we can actually pick it up. Similarly, this is another case of distended stomach. So you can still go lower down and pick up if there is any abnormality. So whenever you see a chest X-ray and you take a section up to here and you see a large dilated bubble loop, you can still go down and see chest X-rays. So this is in crux regarding what we have to see with so much of X-ray to be. I know this is a very exhaustive talk. I've tried to manage it with 60 minutes, but still a lot to learn. Every day we learn a lot in chest X-rays, but with the advent of CT, we don't give much importance to X-ray these days. X-ray can give you much more valuable information than we are. So thank you. Happy New Year and happy Merry Christmas to one and all.
Thank you, Bas. A beautiful presentation. Though it is exhaustive, highly informative. Really, we enjoyed the academic feast. I think we have relived the college days. I was told that you are a very good, busy practitioner in Trichy, but now I could understand you are a very good teacher. Teaching is something amazing. You have ஒவ்வொரு பாயிண்ட்டும் துல்லியமாக நீங்கள் வந்து அப்படி பிரித்து கொடுத்தீங்க. காலேஜில் அண்டர் கிராஜுவேட் செஷனில் வந்து டீச்சிங் செஷன் வந்து வாலில் எப்படி இருக்குமோ த சேம் திங் ரியலி ரியலி வித் த காலேஜ் டேஸ். நாலேஜே இல்லாமல் இதை பார்க்குறவங்களுக்கு கூட வந்து ஒவ்வொரு லைனுமே பியூட்டிஃபுல்லாக நீங்கள் கிளாரிட்டி கொடுத்தீங்க. ரியலி ஹேட்ஸ் அப் டு யூ. Friends, if there are any questions, if you want to clarify, please put it in the chat box.
Sekar sir was very particular. We want the basics. He was very particular. He said complete basics சொல்லி கொடுங்க. Start from the basic scratch position we want to know. So that's why I had to include few things. Otherwise cases போயிருக்கலாம் சார். But
இல்ல ரியலி பக்காவா பண்ணீங்க. இன்னைக்கு பிஸி பிராக்டிஸ்ல வந்து யாருமே பேசிக்ஸை உள்ள பார்க்கறது இல்லை. நீங்க வந்து ஏன்னா நான் பார்த்ததுல வந்து பிஸி பிராக்டிஷனர்ஸ் வந்து தே மே நாட் பி குட் டீச்சர்ஸ், குட் டீச்சர்ஸ் வந்து தே மே நாட் பி பிஸி பிராக்டிஷனர்ஸ். ரெண்டுமே உள்ளது வந்து ஐ குட் சி. இன்னைக்கு நான் பாபாகரனை பார்க்குறோம். இல்லை உண்மையிலே சொன்னால் வந்து இன் டெப்த்தாக உள்ள போனீங்க. மறந்து போனதெல்லாமே வந்து ரீகால் பண்ணியாச்சு. இல்லை ரியலி வெரி ஹாப்பி. நாளைக்கு ஒரு எக்ஸ்ரேயை ரீட் பண்ணா செஞ்சால் டெஃபினட்டாக வந்து எப்படி பார்க்கணும், டாப் டு பாட்டம், சென்ட்ரல் டு பெரிஃபரி, ஒன்றுமே எம்பசைஸ்டு. ரியலி வெரி வெரி ஃபார்ச்சுனேட். அந்த 1 hour வந்து போனதே தெரியல, அவ்வளோ அழகாக கொண்டு போனீங்க. ஐ திங்க் திஸ் வில் பி த ஒப்பீனியன் பை ஆல் அவர் டாக்டர்ஸ் who have joined. If there are no questions in the chat box, we can conclude. Really, thank you, Dr. Bhagaran. In the future, we'll be happy to have you as a speaker for one of our live meetings. You should spare time for us. Thank you, Dr. Bhagaran. And also, one more thing, this presentation has been recorded in total. So, another couple of days, we'll be able to share the offline link. So, you can, in a leisurely manner, you can go through it again. Thank you, these organizers, and thank you, Dr. Bhagaran, and all the participants. Really very kind of you. And also, we wish you the Happy New Year. Thank you.
Thank you.
Shah, yeah. Shah, we can conclude. Shah, you are muted.